Hello, my name's Stephen Doherty, Dr. Doherty, and I'm your instructor for Epidemiology, Biostatistics, and Ethics for your Step 2 CK exam. We begin this morning with everybody's favorite subject, epidemiology. Now, many people in medicine don't understand epidemiology and may not even like epidemiology. You know what? There's a really good reason for that. You see, the approach epidemiology takes, the way that epidemiology wants you to look at things, is frankly different than all the rest of medicine. Just think with me for a second. What's basic medical practice? Well, you have a physician, you have a patient. Physician interviews the patient. From the patient, you collect signs, symptoms, history, some lab values. Wrap all that together, come up with a diagnosis. With the diagnosis in place, you arrange for treatment. With treatment in place, you make sure follow-up happens. Come on, that's basic medical practice, right? That's what we're all getting ready for. Good, listen closely. Epidemiology has nothing to do with any of that. If that's the way you're thinking, nothing that we're going to talk about in the next couple hours really make any sense. See, epidemiology doesn't want you to stop looking simply at the patient in front of you. Epidemiology wants you to look through the patient in front of you, out into the population or community out of which that patient came. Epidemiology, in short, is not about individuals. It's always about groups, collectivities, populations. For epidemiology, disease is not the property of an individual person. Instead, disease is the property of the population out of which that person came. We're looking, therefore, not at disease within the individual, but disease distributed within the general population. Now, this is a little bit of a different approach than we usually take in medicine, but it provides us some insight that we don't have from other areas of medicine. The way we're going to get to this disease distributed in the population is by using numbers. But importantly, we're going to use particular kind of numbers. Everything in epidemiology turns out to be a simple ratio. A ratio, numerator divided by denominator. So the first couple simple lessons are, one, everything in epidemiology focuses on the population, not the individual. And secondly, we're going to track disease in the population by using certain kinds of numbers, particular ratios. Now with that just brief introduction, let me just spend some time working you into the content gradually by focusing on some simple, terms and definitions. So what do we mean if I talk about an epidemic? Well, that's easy. An epidemic, that's when you got a whole lot of disease, right? Yeah, wrong. That's not what an epidemic means. Epidemic is when you have more disease than, here's the key word, expectation. Epidemic is not about having some actual magnitude of disease. It's about having an increase in over and above the given expected rate. If there was one rate and now we have more, we call that an epidemic. What then is a pandemic? Well, a pandemic is simply a worldwide epidemic. Pandemic, wherever I go in the world, I find an enhanced rate of that disease. Common examples of this, in the early 1900s, we had the influenza pandemic all around the world. The influenza pandemic killed more people than were really killed by military action during World War I. The current age, we talk about the AIDS pandemic. Wherever I go in the world, there seems to be an increasing number of AIDS cases. What then do we mean by endemic? Oh, that's easy. Endemic simply means a constant, therefore an expected rate of disease. When the rate of disease is at a regular level going forward in time, we're talking about endemic. Now please note, endemic does not mean a low or high rate of disease. It means a constant rate of disease. With those simple terms in front of us, let's take a look at a series of graphs and look at what this data might look like graphically. Now, this is our first time taking a look at graphs together, so let's do the basics. When you see a graph on your exam, what should you look at first? Well, many people say let's look at the horizontal and vertical axis. Not a bad first choice, but I have a better first choice for you. Let's take a look at the title. You can see here we have in this graph a measles outbreak. Reading the fine grain, you can see here in this graph we're talking about a measles outbreak. Reading the fine grain detail, we're talking about an outbreak in Elgin, Illinois. As you look across this graph, you can see that on the horizontal we have days of the month, and on the vertical we have number of cases. This is the traditional format. Time along the horizontal and cases on the vertical. You can further see that we have here two distinct shadings. One, the sort of grayish shadings, which are other, sort of the background baseline noise here, And then we have the black, more obvious, which is high school cases. Well, when you look at the high school cases, you see a quick upward motion and then a quick descent back down to the baseline again. It goes up really quickly and down equally quickly. Notice there's no slope leading up and no tail leading away. Instead, it looks more like, well, a building. And frankly, if you've ever been to Chicago, that looks suspiciously like the Sears Tower. Well, this particular kind of pattern we call an explosive point source outbreak. An explosive point source outbreak simply means there's a single source of contagion at a single point of time. Single source, single point of time. Basically, if you're there and somebody sneezes, you got it, and if you're not there, you don't get it. Hence, quick up and quick back down to baseline. Please notice, looking at this graph on your exam, you should be able to reason backwards and say, because of this pattern, this is likely a single source at a single point of time. Keeping that pattern in mind, let's go on to look at the second epidemic curve. Here, as you read the title, you see we have a foodborne outbreak. The fine-grained details tells you it's a hepatitis A outbreak at a floating restaurant in Florida. Got to watch where you eat when you go to Florida. Once again, you find along the horizontal the time in terms of days of the month, and once again on the vertical, as is customary, we have number of cases. Once again, we have two shadings here, but this time the legend tells us the shadings being something different. We have the dark shading, this time employees, and we have the lighter shading, this time patrons who have eaten in that restaurant. Now notice we again have a spike going upward and then a return back to baseline, but we have a different pattern here. Here we have a stair step, a slope leading up to the spike, and then we have a decline, a slope leading away. This particular pattern constitutes a single source but contagion across time. This is still an epidemic curve, but we can tell from the pattern that the source of the outbreak now was not there at a single moment in time, but was simply there present across time. Single source, but there that person is across time. The likely source of this epidemic, as you see, is this pantry worker A, who is indicated at the very beginning of the graph. Keeping that in mind, let's move on to our third graph. This third graph is looking at cases of AIDS in the United States. Now, we're not presenting this graph to bring you up to date on AIDS in the United States. This is merely illustrative of, well, how we want to get you to look at and talk about epidemics. Once again, we have time, this time in terms of years along the horizontal, and we have number of cases on the vertical. Once again, we have two shadings. We have, first of all, the white, which are the diagnosed cases leading up to 1989, and then we have dark, which are the midpoint of predicted range from 1989 going forward. What do we mean by diagnosed cases? Well, these are actual measurements of number of people with AIDS. What do we mean by midpoint of predicted range? Well, these are simply guesses going forward in time. In short, standing at 1989, we're guessing about the future. You can tell that this is a projection of the future because as you read the legend, it says predicted range. But you can also tell because, well, you see an upper and a lower bound. That upper and lower bound basically give you the frame in which our guess is taking place. What we're saying is the estimate is what we think it is here, but it could be as high as the upper bound or could be as low as the lower bound. That upper and lower bound constitute confidence intervals. If you don't know what confidence intervals is, we'll talk about that a little bit more as our time goes forward together. Notice that the gap between the upper and the lower bound gets greater as you move forward in time. Well, of course it is. If I'm standing at 1989, guessing about 1990, I'm going to do a better job than if I'm guessing about 1993. Hence, we have a wider gap because there's a greater chance of being wrong. Now, this is still called an epidemic curve. But if you keep in mind the previous two graphs, this one's distinctly different. Here we don't have a spike up and then a return back to baseline. Instead, we have an ever-increasing upward slope moving from the left to the right. Why is this still called an epidemic curve? Well, easy. If you're a physician practicing medicine in the United States in the year 1982, how many cases of AIDS would you expect to see? The answer, of course, is none. You didn't even know what AIDS was, at least most physicians didn't, in the year 1982. And so you can now see that any new disease outbreak is by definition an epidemic. This epidemic is about over and above expectation. Anytime we have a new disease, it is by definition an epidemic because we expected none and now we have cases. Remembering, epidemic is not a lot of disease, it's over and above expectation. Now, suppose instead of the predicted path of AIDS here with an ever-increasing slope, suppose from 1989 onward, AIDS actually flatlined. We continue to have a lot of it, but we had instead a standard constant number of cases going forward. Well, if that was the case, we would no longer talk about AIDS as an epidemic. Instead, we talk about AIDS as, endemic, because endemic is a flat, constant amount of disease. All right, with those simple terms out of the way, let's now return to our main discussion and focus on epidemiology full bore. Remembering, epidemiology 1 is not talking about individuals. Epidemiology is talking about groups, collectivities, populations. And 2, epidemiology wants to look at the distribution of disease within these particular populations. We're going to do that by using numbers, but now here's the key idea. Epidemiology is all about ratios. When we're tracking disease within the population, we're always tracking a simple ratio, numerator divided by denominator. The numerator, that's fairly easy. These are the actual clinical cases of disease. These are the people that actually have the disease, the people you might look at and be treating in your office should you know about them. But the important number is the bottom number, the denominator. Denominator here are the potential cases of disease. Not the people that actually have the disease, but the people who could have the disease. Not the people who may ever even get the disease, but people who in an alternative universe, it's a possibility for them to have the disease. This simple ratio, actual cases divided by potential cases, is the core intellectual content of epidemiology. If you can remember this simple idea, everything in epidemiology is a ratio, numerator divided by denominator, you're well on your way to end what is many people's confusion in this particular subject. Numerator, denominator, actual cases divided by potential cases. Now, I need you to understand that on your exam question, indeed in the real world, it's the denominator that matters most. Everybody seems to get the numerator right, the actual clinical cases, but the denominator is where the intellectual work is, and therefore where the right or wrong issue on the exam question will be. We're talking about the denominator. What we mean is people that are, to use a different phrase, at risk. At risk. Not the people that have the disease, but the people who could develop the disease, who have in some sense a greater chance than average of developing the disease. At risk, the potential cases. I need to make really sure you understand what this ratio is, so let's try a simple analogy together. Suppose after watching this tape you decide, enough of this. I don't want to do this anymore. I know. I'll go buy me a lotto ticket. And with that lotto ticket, I'll win millions and millions of dollars and I won't have to do this anymore. Okay, you have your ticket, at least in your imagination. You have your ticket? Wonderful. Now here's a simple question. Are you going to win? You have your ticket. Are you going to win? Well, the answer, of course, is no, not at all, not a snowball's chance in hell. Your odds of being killed by lightning today are so much higher than your odds of winning lotto. You think you're going to win lotto? No, you're not going to win. But by buying that ticket, although you're not going to be one of the actual winners, by buying that ticket, you have become one of the potential winners. If you want to have a clear sense of how we differentiate that numerator, actual cases, from denominator, you have it right there. What's the contribution that epidemiology brings to medicine? Simple. To look beyond the people who are the, quote, winners, the people that have the disease, to the people that are the potential winners, the people that bought the ticket. If this sounds like it begins to resonate with preventive medicine, well, then you're following me. Because epidemiology is, of course, the basic intellectual tools that we use for much of our preventive medicine. It's actual cases divided by potential cases, the winners divided by people that merely bought the ticket. Now, so we're clear here. If you're in the numerator, the actual cases, are you also in the denominator? Well, the answer to that is, of course, yes. Because this is, in essence, a fraction, where what you have on top is a subset of what's on the bottom. The numerator is merely a piece of what's on the bottom. Understand, if you won the lottery, you must, of course, bought the ticket. So when we talk about numerator, we're talking about that actual cases as a subset of that denominator, the potential cases. Now, getting the right denominator is what it's all about. Getting the right answer depends on getting the right denominator, and the right denominator is simply decided by a very clear idea: who is at risk. If you think someone's at risk, you leave them in. If you think someone's not at risk, you take them out. If you're not sure, you leave them in just to be conservative. So let's try a simple exercise here. Suppose I want to do some research in Chicago, where I'm from, looking at breast cancer in the Chicago area. Breast cancer in the Chicago area. So I take my staff, hire them, send them out all across the city, border to border, and with great effort, they find every single case of breast cancer in this city of Chicago. Boom, that's my numerator. Now I have to come up with the right denominator. Well, let's think. I did the research in Chicago, right? So the right denominator is obviously the population of Chicago, right? No, wrong. One reason I don't want to use the population of Chicago is, well, men, although they can get breast cancer, there's maybe 1,300 cases a year in the United States, they're not at risk the same way women are, right? So using the whole population of Chicago doesn't make any sense. Let's constrict our denominator to simply women in Chicago. That's a good denominator, right? Once again, wrong, because, well, how many cases of breast cancer do you think there are in children? How many cases of breast cancer are there in teenagers? Frankly, until you get up to roughly age 30, there's empirically nothing to talk about here. The right denominator, therefore, is not the population of Chicago, not even women in Chicago, but maybe women over the age of 30 in Chicago. Now, although further refinements are possible, I hope that illustrates the point sufficiently. The point is, we're going to leave out the people not at risk, so our denominator is just the people that have that real potential for having the disease. But look what happened. We shrunk our denominator from Chicago down to women over age 30 in Chicago. That ratio became a lot larger than you might have originally anticipated. And I remind you again, it's all about the denominator. Everybody gets the numerator right on the question. It's getting that denominator that makes all the difference. In fact, you got to know, when I'm talking to students for the first time about epidemiology, what I'm always listening for to understand whether or not you get it is whether you talk to them about the numerator or talk to them about the denominator. The rookies talk about the numerator. The pros focus on that denominator. That's where the action is, and that's where the right answer is on your exam question. Now, we don't take this ratio and stop. We're now going to do one final thing. We're going to convert the ratio into being a rate. We're going to do that by giving it a standard multiplier. By giving a standard multiplier, it's now much easier to compare changing numbers across time and indeed to compare between different populations. Now, any number could be used for standard multiplier, but most often it's per 100,000. Why per 100,000? It's a nice round number, got a lot of zeros in. It's easy to work with. So we're going to use something that's easy to work with. Most of the data we get from the Centers of Disease Control and Prevention in Atlanta comes to us in terms of per 100,000. So per 100,000 is the first of several rules of thumb I will talk to you about. Rules of thumb means simply this. If you're not sure what the answer is on your exam question, guess this. It won't always be the right answer, but it's your best guess as to what the right answer is. Per 100,000 is your best guess. But of course, not everything, let's be clear at the outset, is per 100,000. If I'm talking about infant mortality, that's per 1,000 live births. Talking about divorce rate, that's divorces per 100 marriages. Very good again. But most things are going to be per 100,000. And so with that in mind, let's take a crack at a relatively straightforward but deceptively difficult question. Here we have a simple one-line question that mirrors something on the Step 2 exam several years ago. The question asks you, quite directly, what is the current rate of AIDS in the United States? What's the current rate of AIDS in the U.S. today? You happen to have that figure right on top of your head? No, of course not. Who walks around with that kind of data in their heads? All right, well, I do, but other than me, who walks around with that kind of data? And so you look down at your response options and you see A, 191 out of 1,000. You see B, 276 out of 10,000. You see C, 210 out of 100,000. You see D, 15 out of 100,000. You see E, 987 out of 1 million. A, B, C, D, E. One is right. The other four are certainly wrong. And your choice is, because when I pause, you need to say the answer. You don't have to tell anybody else, but you have to make a choice. Because getting yourself ready for your exam, the essential process is to get yourself to make a choice. And if you're not sure, yeah, that's going to happen a lot. Make a choice anyhow. So the right answer here is, well, most people look at this question and say, well, look, it's got to be either C or D, right? Because I've just been talking to you about per 100,000. So you know it's got to be either C or D. Most people at this point are not sure which one it is. And so many people at this point adopt the following thought process. Well, let's see, C or D. Gee, I heard there's a lot of AIDS out there. Let's go for the larger number. The answer must be C. Very good. You gave yourself an excellent reason to pick the wrong answer. C is not the correct answer. D is, in fact, the correct answer. Now, let's have some conversation about what's going on here, what you should do in this question, and what your thought process should be. If you get a question down to two options, if you know which one it is, go ahead and pick it. But if you don't know which one it is, then the right exam process is to stop thinking and take a simple random guess. In other words, if you knew it was either C or D but didn't know which one, your right action is to basically go eeny, meeny, miny, mo. Pick one and get out. Now, is there a way to get this question right without that kind of guessing at all? Absolutely there is. But it requires you to understand what the question is about. Now, this is a simple one-line question, much shorter than the typical questions you see on the Step 2 CK exam. Questions on the Step 2 CK exam tend to be about 100 to 110 words long. They're fairly long questions. This is, of course, much shorter than that average. But even with this short question, the question is, what is this really asking you? What's this question really about? This question's about what? If you're thinking it's about AIDS, sorry, you've missed the issue here, because you don't have to know anything at all about AIDS to get this question correct. This question is not about AIDS, it's about disease rates. This question simply asks you about disease rates in the United States. Now, here's a fact to let you get the answer correct without any guessing whatsoever. Most disease rates in the United States are under 100 per 100,000. And the vast majority, 95% or more, are under 50 per 100,000. I'll say that again, most under 50 per 100,000. With that piece of information in mind, now it should be clear what the right answer is. The right answer here is D, because it's the only one in that range under 50 per 100,000. In fact, as I read it, it's the only one that's not, frankly, silly. Everything else is too far out of the range there. Okay, quick review of the points I want you to walk away from this question with. First, when you don't know what the answer is, get it to two choices, stop thinking, and guess. I know 50% is not your goal in the exam, but it's a wonderful foundation on which to build with questions where you have a higher probability. Second, most disease rates in the United States are under 50 per 100,000. So in this question, we're going to go for the one under 50 per 100,000. And third, the real hard part about these questions is not the answer, it's grabbing a clear sense of what the question's about. This question's not about AIDS, it's about disease rates, and so I can use that fact, under 50 per 100,000, to know the correct answer is D.